Hello, hello, and welcome to another episode of Talking All Things Cardiopulm. I am your host, Dr. Rachel Burriesci. As we get started with another episode, I'd like to take a moment to highlight our sponsor, Jane. Jane is a complete practice management software that makes it easy to book, chart, bill, and get paid all online. The team at Jane knows that getting paid is one, if not the most important parts of running your practice. With that in mind, they've created a fully integrated PCI-compliant payment solution called Jane Payments that makes for convenient online payment experiences for you and your patients. With Jane Payments, you can collect credit card information through your online booking or intake forms, send one-click payment request emails or SMS for outstanding balances, and you'll never need to leave Jane to reconcile your payments. Curious to learn more? Head to jane.app/payments. You can also use this code Cardiopulm1MO at the time of sign up for a 1-month grace period on your new Jane account. A small gift from Jane to you. So I just want to take a moment and thank Jane, my EMR software system, for sponsoring this podcast. And because of that, I felt it would be super appropriate to talk a little bit about how I use Jane and really about documentation. I know documentation can be a real sticking point for people. It feels laborious. I think it's probably the number one complaint that I hear from PTs getting their charting done, getting their documentation done. And I really wanted to take a moment to talk about documentation because as much as it's a pain, it shows our skill. And being in this business, this game for the last 14 years, I've seen the evolution of technology and I've seen the evolution of documentation. When I started as a PT 14 years ago in New York, believe it or not, we were on paper. We had paper charts. We had, progress notes that we would write on pre-filled out templates, and then we would kind of fill in the blanks. And the benefits to that were you literally write your interventions, your assessment, and show your skill in sentences. And the obvious problem with that is it's really not transferable. If patients switch to different hospitals, it's hard to send that information. And most importantly, it was awful to read. Doing a chart review on paper was the absolute worst, reading someone else's handwriting and literally feeling like you didn't know what was going on. So obviously the move to the digital world was needed and has made things so much more connected, right? Even for myself, I lived in New York and Michigan and now here in Kansas, and I have most of my medical record all through one system. And, we can see that I can transfer it to new physicians here. So obviously the move to the digital world has been phenomenal. But there's also some limitations. I kind of saw this evolution of documentation. And when I was in New York, we had, after the paper situation, we had a digital medical record. And it had some click boxes, but it was mostly text boxes, right? So like there were certain things that you could click off, but for the most part, you were writing to fill in the blank. And to be honest, I really liked that. I think it gives you a little bit of both. It was super efficient. You could click the things that you knew you were going to do, like billing and maybe some intervention, click box type stuff. But it always allowed you the opportunity for subjective and assessment and the ability to show your skill, which I'm just going to come back to this and remind you that that is what documentation is doing, on top of which showing progress for your patient and change over time, right? Obviously, there's the insurance aspect of it and how that can be manipulated by different companies. But for the most part, in its organic sense, the point of documentation is to show your skill, to show progress for a patient, and to show your assessment. And at the end of the day, that gives you weight, right? That shows that this is your skill set, this is your knowledge base, this is what you found as a clinician. And so that part I kind of like. It's just putting together your eval on paper. So some things I love about Jane is the ability to customize to what you need. So now in my current mobile virtual PT practice, I'm able to customize my evaluations and treatment sessions based on the things I know I'm going to be assessing. And if you are on Jane, then you can look into the community and pull my templates if you were interested in pulling some of the Cardiopulm stuff that I do. So I have templates specific to COVID. I have templates specific to long COVID. I have templates specific to my pulmonary patient versus my cardiac patient. And then sometimes I just have like a chest exam picture. And it's really helpful because it saves time on that point. But the way that Jane is set up is it has the ability to do some click box type stuff, but it always allows you to actually give text form, which I appreciate. So when we move to this like digital world, and the two main EMR systems like out in the hospital world is Epic and Cerner. I've never used Cerner, but I've heard it's very similar to Epic. But I've used Epic now in 4 different hospital systems. And I think I was always there when it like just started. So, the Epic team comes in, you get all this training. Here's the thing. It's very similar, but it's different. And you can customize it to an extent. But the point of using a system like Epic isn't about showing your skill. The 2 things that I've heard quite a bit is that it's for efficiency purposes. And the second thing is to actually collect data. And I learned that when I was in New York, because I would talk with the assistant to the president. And that was the main thing, right? So systems like Epic can allow you to pull data, diagnosis, length of stay, potentially EBL, like things that we were manually collecting when we were doing research projects, you could do with Epic. So that sounds really helpful, especially from an administration perspective. It can help with showing stuff with financials, right? So if we're talking length of stay, that's easy to pull. The problem with like the big picture stuff is that EMRs can't pull text. It can only pull information out of cells. So those click boxes are very helpful in the world of data. In the world of efficiency, I will be quite honest with you, it takes me just as long to write a text-based note than it does to do a click-based Epic note because there's so many cells and you're typing in this tiny box. And I mean, that's my opinion. And just to be clear, all of this is my opinion. But I really like Jane. I've really been able to customize it. I'm still not using it to its full capacity, but I'm excited to keep learning. And the features in the community that Jane has created, I think, is also phenomenal. So just a plug for Jane. I will link their website in the show notes, as well as the 1-month grace period if you do sign on for Jane. All right, so let's jump in a little bit more about documentation for Cardiopulm specific type topics. I've taught documentation in DPT programs. I've taught documentation in residency programs. I've taught documentation with current mentees who are trying to sit for CCS. And the main thing that I typically tell my students, and I'm just going to use that word as a general word, global for any type of student, is that you want to be able to show skill, articulate your thought process, show progress, and be specific to what you're doing. So we're going to start with the assessment piece. We're going to start with the objective piece, and we're going to talk about what specific things that you might be doing in your exam that you can put in the objective section. So I'm going to speak globally in like a SOAP note type format, subjective, objective assessment plan. And we're really going to hang out at the objective and assessment technique because as I was writing a quick little outline, I realized I could talk about this for a really long time. And this might be review for you. This might be brand new for you. I don't know. So please give me feedback. Please let me know if you got something out of this. And honestly, if you start using it in your practice, more importantly. All right, so things that we can include in our objective section are those objective things that we are performing in an examination, okay? So vital signs, top of my list in the Cardiopulm world. And to be honest, and I'm hoping to make some push across settings is that vitals are included across settings. It shouldn't just be an acute care thing, period. We've talked about the importance of vital signs in the sense of overall health and wellness, in the sense of direct access, in the sense of safety with exercise. And then in my world is the ability to tolerate exercise. And what your numbers show and how a patient feels don't always match up. And so having both can be very beneficial in how you progress a patient. So vital signs, vital signs, vital signs. Vitals are vital. Hashtag that. And then when I show vital signs, I'm going to give you pre, during, and post, usually as a minimum. And that's really, to be honest, because what that does for me is that helps show skill in the interventions that I've provided, right? You have to take a pre, because if you don't take a pre-vital, then you don't know what the change is. And just taking a post-vital doesn't really tell you much, right? It's just a number. So it becomes less than just a number when it's associated with something and when you can see change. So in the world of orthostatics, like we talked about last episode, you're probably going to take a ton. And I'm not going to lie to you, if you are not someone who is currently taking vital signs in your practice, specifically in the acute care setting where people can be in and out of rooms within 15 minutes, I'm not going to lie, this is going to add to your time. I know, because I do this, and I am usually never in and out in 15 minutes. So if you're doing orthostatics, you're going to have multiple positions that you're taking it in, right? So you at minimum have 3, or I should say 2 just to start, supine, stand. And then if you're in your intervention section, you might be doing supine, sit, stand to help that patient through that lightheadedness. You should take something during, right? What interventions are you doing? Are you doing strengthening? Are you doing interval training? Are you doing continuous ambulation or endurance training with a peddler, right? Depends on what you're using as your intervention. Are you doing dynamic balance? Whatever it is, are you doing stair negotiation? Are you assessing after that specific intervention? Because that number is going to tell you how that person tolerated. So the objective is the number, and hopefully in sequence, and the assessment is going to describe that response, which we'll get back into later. So blood pressure, heart rate, SpO2 are probably my top 3 vital signs that I always document. If I have a patient with pulmonary diagnosis, if they're vented, I'm typically doing respiratory rate. If I don't do respiratory rate, which is not my go-to vital sign, although I do document it, I typically document IE ratio, their inhale to exhale number, because that usually gives me more information about how that person's tolerating. Are they breathing with a 1-to-1 ratio? Are they apical breathing? That's in your objective section. Chest exam, right? That's a big umbrella that encompasses many different assessment techniques, and that throws students. So if I say assessment techniques, I mean examination techniques, just to kind of be clear about it. But one chest exam that I typically perform is chest wall assessment, upper, middle, lower. In the acute care setting, I typically do upper and middle. I don't necessarily always do posterior, which is lower, pending the position the patient's in when I'm doing the assessment. That tells me if there is problems with symmetry and timing. So in your objective section, you're going to document that. Decrease lateral costal movement, left greater than right. Decrease timing to left expansion. Increase superior movement of upper chest. Decrease lateral costal movement, period, right? That is an objective finding because your skill as a physical therapist says that is objective. It is not my opinion. I have the ability to assess that on you, and I am assessing it, and this is what I found. It's objective. Auscultation. If you are trying to get better at auscultation, if you are planning on sitting for the CCS, if you want to do more in the Cardiopulm assessment intervention world, start auscultating. If you need help with understanding auscultation, shoot me a DM. We can do a one-on-one call. Auscultation is a important skill that is not sometimes emphasized as a PT skill. And I'm saying that really loosely, and I kind of have an icky feeling about saying that, but it's true. If you've listened to my episode on Wear the Damn Stethoscope, there's like some feeling about it. Most PTs aren't wearing a stethoscope. If you are interested in auscultating, it is an amazing skill to have because it gives you a ton of information. When you auscultate, your findings go in the objective section. You're looking for normal versus abnormal versus adventitious sounds. I'm not going to go through all those sounds today. I keep saying I'm going to do this next. I'm going to put that on the list as maybe my next episode. The reason why auscultation is so powerful, and it's for a number of reasons, but it gives you so much information. When you auscultate, you will hear something that is abnormal or adventitious, and it's typically linked to something diagnostic, something related to a disease process. There's no guessing. It typically tells you what it is. There's some gray, but for the most part, when you hear rhonchi or low-pitched wheezes, I'm still never really going to give in on that name. There's mucus, period. If you have crackles, there's some differentiation. It could be atelectasis, it could be fluid, either in the alveoli or the pleural space, but it's telling you pretty concrete information. When you auscultate, when you're actually performing that assessment, you want to be very systematic about your approach. I always start on the patient's right and then compare to the left and then move inferiorly. Some textbooks will tell you go right to left and then down. I go right, left, right, left, right, left. Does it really matter? No. What matters is that you're listening, that you know what segment or lobe you're over, and that you're documenting that appropriately. So the reason why I always do it the same is I'm going to remember that much easier, especially if I'm in a contact room and I can't write it down right away. It's easier for me to hold in place what I heard. So auscultation just gives you a ton of information. And then my favorite part is if your patient has rhonchi, they have known mucus, they have a junky cough, you auscultate, you hear it, positive rhonchi noted to anterior left lower lobe. You do breathing exercises, airway clearance techniques, and then you re-auscultate and you hear air, normal breath sounds versus rhonchi. Dopamine hit. Pre-post assessment in real time. You've made an actual change for that patient. Likely that patient's gas exchange or SpO2 has improved, and you've moved whatever was in there. So it's awesome, right? You get that validation, you help that patient, and you can physically do an anecdotal pre and post in real time. That's awesome. There are a ton of other assessments like mediate percussion, fremitus, voice sounds that all have the same purpose, which is to assess if there is consolidation or not. The problem, and I don't want to say problem because they're good assessment tools. I usually use them as accessory tools versus my go-to. You get more bang for your buck with auscultation. The reason is, if I do mediate percussion and I hear a dull sound, that also indicates that I have consolidation. But it's going to sit, consolidation as a word means mucus, fluid, or tumor. Which one? I don't know. You have to do another assessment. So in a world where efficiency reigns supreme, go to auscultation. Now in residency programs, or if I'm teaching mentees, I teach them to do these techniques. Why? Because they're going to ask you questions on it. And you need to understand what it means. And you also need to have a trained ear, even though you don't have a sound on a test. to assess, they're going to ask you questions and you're going to have to be able to link it to a diagnosis or a problem. Ooh, so sorry. It's important for you to be able to make that connection. And for me, as an adult learner, I can't just memorize. So learning in real time is doing it. That hands-on is really going to make it stick. Also, it's fun, right? My favorite part about working at the VA and running pulmonary and cardiac rehab was doing the initial assessment, the initial examination, and post-examination, because you can see this tremendous change in your person and you can do all of the things, and it's so much fun. In pulmonary rehab, I would do mediate percussion on my patients who had emphysema. And guess what? It's going to be hyper-resonant. Why? Because they have a lot of air. Why? Because they have emphysema. Real-time learning. And it's fun. You do agophony. Do I typically do agophony on my acute care patients? Not really, unless I'm auscultating and they're talking, which most patients do, and it's really garbled, then I'll do it to just check myself. But when you have that time to just do a chest exam, why the hell not? It's fun. You can hear it. You're like, oh my God, that's an E to A change. And then when you document it in your objective section, you're going to say E to A change noted in a posterior right upper lobe or wherever you heard it. What would that tell you? Patient has consolidation. What type? You don't know. Mucus, fluid, or tumor. So auscultation is a pretty efficient tool. It doesn't take a ton of time. It takes a little time, but it takes skill, right? You have to know what you're listening for. And before I scare anyone away from auscultation, don't be. The patient doesn't know what you're listening for. Listen. Start hearing it. Start making connections. Read the chart. Auscultate. If it says patient has crackles in bilateral lower lobes, go and auscultate the bilateral lower lobes. And if you hear something funky, it's probably crackles because it already told you. But now you can start to connect crackle sounds. Okay, so just one way to kind of bring that in. Fremitus is another one. Do I assess fremitus? Yeah, but usually it happens in a not specific way. For instance, if I'm doing chest wall exam and the patient again maybe talks, you will note fremitus. And I'm like, oh, there's vibration that's increased on my right side. Then I will say, hey, can you say 99 and reassess it? Now you're going to put that in your objective section. Positive fremitus noted to whatever lobe segment that you're on. Some mediate percussion, voice sounds, fremitus, they're assessment techniques that you can use during your exam or examination techniques. Sorry, it's hard to switch those words clinically to teaching sometimes. But I'm going to still get more information out of auscultating than doing any of those techniques because they're going to tell me the same thing. So typically I'm not going to do fremitus and mediate percussion or mediate percussion and voice sounds because they're going to give me the same information. At the end of the day, you kind of have to finish with auscultation. So I usually start with auscultation, and if I want to check myself, I might use one of the other techniques. Or if I'm teaching, or if you just want to hear it because it's fun, then you could do it. And yeah, I'm literally saying the word fun because it's amazing when you get that sound. So I have a stethoscope from Littman. It's called the Echo, and you have the ability to record. But I don't use it at the hospital setting because you would have to consent for that recording. I have had some perfect sounds, and every time I'm like, I wish I could record it because I don't get that frequency outside the hospital. And those abnormal sounds are typically apparent when they're sick enough to be in the hospital. So I'm hoping to figure that out at some point. Cough assessment. If your patient has pulmonary diagnosis and or heart failure, do a cough assessment. And as you all know, if you treat patients, most patients have a plethora of diagnoses in their past medical history. So just because someone is seeing you for a heart or lung condition or whatever they're in for from the hospital setting doesn't mean that they're not going to have a problem with the other system. So sometimes I just do a cough assessment throughout. And if they cough during the session, then I'm going to tap into that too. When you're documenting cough assessment, you're going to have the patient cough as if they were going to clear mucus. That's the cue. Don't give them any other cues. And then you're going to assess what they do. You're assessing the 4 phases of a cough. You're assessing if the cough is strong or weak. And if it has a sound, and if it's productive or non-productive. All of those things get put in your objective section. So if patient, for instance, is post-sternotomy, you can assume that they're going to have a weak cough. And you're going to assume, you're going to assess it. But right now, we're going to assume that they have a weak cough because they have poor inspiratory effort. Why do they have poor inspiratory effort? Because they have a giant incision down their sternum. If they have a poor inspiratory effort, they're going to have a weak cough. You document that in your objective section. You talk about it in your assessment section. Okay. If you're using any kind of scale, RPE, RPD, angina, PAD scales, whatever it is that you're using, goes in the objective section. Same thing, pre, during, post. If you are using an RPE scale, be clear that you're using a 6 to 20 scale versus a 1 to 10 scale. Same for RPDs. There's a ton of dyspnea scales available. There's a 1 to 4 and 0 to 10 are the most common. Just be clear about what you're documenting. Don't just write the number 1 because that means nothing, right? If you're using the RPE scale, you're going to say at rest, patient notes or whatever, 9 out of 20 at rest, 12 out of 20 during exercise, returns to 9 out of 20 post-exercise. The RPD scale, same thing, 1 out of 4 or 2 out of 10. Give the range, because if you just put one number, it doesn't mean anything. So what you document matters because it gives a lot of information about the patient. It also gives handoff to the next person, right? Especially in the hospital setting where you might not see that patient tomorrow. You want to give good handoff to the next therapist coming in so they can be consistent with what you did. And we can increase consistency by having good documentation. So there's that. In the objective section, you're also going to have outcome measures. So if you perform a 5 times sit to stand, a 30-second sit to stand, a tug, a 6-minute walk test, a 2-minute walk test, a 2-minute step test, gait speed, whatever it is that you're doing, you're putting it in the objective section. That's super important, right? From an insurance perspective, it's super important, but also for like progress of your patient, pre and post. That might be days away, but it's going to be important to see the change over time. That shows skill in what we do. And it is important for us to continue to show skill. Okay. I feel very passionate about this because there was something on Instagram the other day and I held back. I shouldn't have. I probably should have just, put my opinion on there, but whatever. There was a post on a certain site and it was an anonymous question from a PT or a PT student. And it said something along the lines of, this PT told me not to go into acute care because all you do is put people in chairs and walk them. So I'm going to give you my response that I probably should have done on Instagram. I'm just not that person. So my response is this. There is a stereotype in every single setting. I could tell you all of them, but I'm not going to be any better if I do. We, as a profession, as PTs, if you're a PT, I'm talking to you. If you're anyone else, sorry for the rant. Students too, pay attention. We, as a profession, need to do better. Stop shitting on each other. We do not help our profession by saying everything bad about acute care therapists or SNF therapists or outpatient PTs. Whatever it is, stop it. The reason why I feel so something about showing skill in your documentation is because the stereotype exists. And the stereotypes exist because it happens. So to decrease the stereotype, to decrease that conversation that's happening, show skill, use your knowledge, use your entire scope of practice and do better. There are a ton of reasons why we can't. Productivity limitations, time limitations. I get it. I live it. I'm in it. But if you have the ability to use your skill to assess the whole person, do that. And then when you document, show it. Because we are a skilled profession with a ton of knowledge base. I don't want to see it go away. So when I get passionate like this, that's why. Because I think every human needs PT, like at this point, including myself, because you are going to have impairment over time. You're going to have decrease in some sort of aspect of your life because you stop doing. No matter what age group you're in. I just went and played basketball yesterday. I haven't played probably since last summer when I was home with my niece. Guess what? Sprinting for the ball back and forth, jumping for a rebound, cutting, dribbling. If you don't use it, you lose it. That is fact. My balance isn't as good. My jumping height, my power, it has decreased. Why? Because I'm not doing it. And if we don't do it, extrapolate further, people are going to need us. Period. So be proud of who you are. Be proud of your profession. And let's raise each other up instead of the opposite. All right. I digressed. Sorry. It bothers me. I hear it so frequently. It's like kind of starts pulling at your heartstrings a bit. I'm proud of my education. I'm proud of my profession. And when you hear the crap and it's like negativity, right? Negativity just kind of ferments and spreads. We got to stop that spread. We got to use the other side of it. And we do it by showing skill, by using our knowledge, by using our full scope of practice. So in the world of documentation, in our objective section, we're putting everything that is objective. And what's objective for us as a profession is a slew of things, right? It's the skills that you're using to assess your patient. Your exam techniques all go in your objective section, right? No paragraphs in the objective section. There are a ton more. I'm not going to touch all of them. But in certain situations, like for instance, if I am maybe doing a research project on breathing, I might assess MIP and MEP. If I have patients that I'm seeing like in person, I might assess MIP and MEP. If they're known ILD, if they're known emphysema patients, like if they have a known lung disease, that's a great pre and post. And I can do that. And I will include it. You can do tape measurements of chest wall mobility, diaphragm excursion. Do I typically do that? No, unless I'm doing something more precise, research-based. Diaphragm assessment was one thing I didn't mention. Assess the diaphragm. It does not take much time. Document your findings in the objective section. Is it normal? Has appropriate excursion, good timing, left first, right? Or is it paradoxical? Those are all things that go in that objective section. Your interventions, it's what you did in that time. Did you do breathing exercises? If you did, which ones? How many reps? How many sets? Maybe some specific cues if a patient needed cues. Airway clearance techniques, what'd you do? Percussion, vibration, huff cough, functional cough. What cues again helped? If you're working on endurance training, did you do continuous endurance? Did you do interval training? Did you use level ground? Did you use treadmill? Did you use a new step? Did you use a peddler? How many minutes? Did they need sitting rest breaks? Did you assess vitals during that time? So on and so forth. Did you do strengthening? How did you do strengthening? What did you do? Reps, sets, type, right? Think about that FIT principle. Frequency, intensity, time, type, basically, froze up a little bit there, basically is what you're putting in this section. If you did any balance activities, what did you do? Right? What did you do during your session? Very specific. Reps, sets, position, helpful, right? Because again, if I'm coming in tomorrow, I want to be able to continue what you did. Okay. In the acute care world, you have mobility as well, right? Like what physical assist? I'm not going to get into that today, but you want to give those specifics. Where did you provide the assistance? At the trunk, the lower extremities? What cues did you provide? All of that goes in that objective section. And then the assessment section is something that I feel like we're losing in the world of digital medical records, EMRs, right? That's why I love Jane, because I kind of am back to being able to write freely without a constraint of a tiny baby cell and just clicking boxes. The assessment section is the storytelling. It's showing what your patient demonstrated. It's giving your PT diagnosis in a full sentence. It's actually one of the things I loved about my residency. They harped on note writing. They taught me to articulate better verbally and in written form, because you have to show your skill and you have to show what the patient is doing. So I'm going to give you some words that hopefully you can use in your documentation, in your writing, in your practice, or even when you're articulating with the docs. One of the things I actually really loved that I learned in the residency program was writing the impairments related to the guide to PT practice patterns. Now, the guide to PT practice patterns are gone, but the words still work, and I like to use them. So some common impairments that you're going to find in the Cardiopulm world is gas exchange, ventilatory pump dysfunction, aerobic capacity, airway clearance. Those are 4 very common impairments for your Cardiopulm specific patients. Yes, pretty much every patient, impairment of strength, impairment of balance. I mean, I'm not going to lie, in the acute care setting, it is very prominent. And we're going to talk about why that matters after. But if they're showing it, you're writing it, right? Okay, so here's the verbiage I like to give to my students who are starting to write notes, who are working on their documentation skills, to my residents who are trying to articulate their message. Write an assessment like you would write an ESPN snapshot. If you watch ESPN and you didn't watch the game, whatever sport, doesn't matter, they give you a 30-second snippet of the entire game. It's the highlights. What happened? What happened that was good? What happened that was bad? What was something that really stood out to you? That's what you're doing in your assessment, okay? So if you're writing your PT diagnosis, let's just use the example of a heart failure patient. Patient presents with impairment of gas exchange, maybe ventilatory pump dysfunction, and aerobic capacity in the setting of acute on chronic heart failure. Patient demonstrates inappropriate vital sign response with activity. Inappropriate vital sign response with activity is showing you that person has an aerobic capacity issue, right? You're describing why that's the diagnosis. I typically write how much of a drop or exaggerated response occurs with, let's say, ambulation, or drop in pressure with sit to stand, or whatever. Describing it is showing your skill. And what did you do about it? We switched to interval training with a 2-minute walking period with reassessment with normal vital sign response, repeated 5 times with additional response, right? Because now you're going to continue interval training. Gas exchange, patient presents with impairment of gas exchange. Well, typically that's telling you that we have a problem at the alveolar level. Something is happening that's causing likely a drop in SpO2 or requirement of oxygen. So what are you looking for in that assessment world, or what are you saying in that assessment world? If your patient has heart failure, they might have fluid. They probably have pulmonary edema, and that may be causing potentially a gas exchange issue. Patient demonstrates drop in SpO2 with ambulation of 100 feet, requires up titration to 2 liters of oxygen to maintain. You described what happened. You described what you did. Able to recover with pacing, rescue position, breathing exercises, right? You're throwing in what you did. How did you affect this? Patient demonstrated this. I helped with this. Okay. Airway clearance. We're not going to do airway clearance for our heart failure guy, but let's do ventilatory pump. If your person has bilateral pleural effusions, they have fluid in their pleural space. You can likely guess that you're going to have decreased chest wall expansion. Patient presents with left greater than right chest wall expansion, improved with lateral costal breathing and manual overpressure. Your technique helped improve the movement of the chest wall. Now, big difference between gas exchange and ventilatory pump dysfunction. Gas exchange is occurring at that alveolar capillary membrane. Ventilatory pump is ventilation, the actual act of moving your chest wall and diaphragm. Okay. Aerobic capacity, we talked about that one. If you had a patient with airway clearance techniques or impaired airway clearance techniques, let's think about your patient who has a lot of mucus. Patient presents with impairment of airway clearance, demonstrates decreased inspiratory effort with coughing secondary to sternal incision. Improved with inspiratory hold technique to progress cough, or patient lacks phase 1 inspiratory effort. Improved with cueing for increased tidal volume. What is the problem? What did they demonstrate? How did you help? Or did you help, right? Because you don't always make the change in that moment. The point of your assessment is to give your opinion. We're asking you as the professional to tell me what you saw and what you expect and what you observed and articulate it to me. And then you give your recommendations. So a common sentence I'll say at the end is recommend continued PT or continued inpatient PT for, and that should reflect your impairments, for breathing exercises, for airway clearance techniques, for endurance training, for strengthening, for balance, so on and so forth. Now, one thing I did want to just kind of jump in and say is you're not just doing a chest exam. You're not just doing a cardiopulm exam. You're typically doing a full assessment of the whole person, right? Because we're not just one system. We are a whole person. And the more and more I niche down, the more and more I know I have to assess other systems because they all work together. Nothing works alone. And so you better believe that I do strengthening with my patients, even in the hospital. And no, it doesn't look like RDLs and goblet squats because they physically can't do it yet. But it might be more functional based, sit to stands versus squat. Step ups, right? I mean, that's a regular exercise that we do in the gym as well. You have to meet the person where they're at. And I hear a lot about dosing. Yeah, we probably likely underdose quite a bit, but my goal is to at least get people to do strengthening with their patients in the hospital, period. Because there is so much benefit. When we do strengthening exercises, we can improve the gas exchange that occurs at the muscle level. We improve O2 extraction from the muscle, makes the muscle more efficient when it gets stronger. It can create angiogenesis, very helpful in the patient with peripheral arterial disease. And it's going to help improve function, right? If you have weakness, likely, you're not going to be able to perform a sit to stand. I see it every day. Here's the thing. Everything is connected. So if you have a cardiovascular or pulmonary issue and your primary concern or your chief complaint is shortness of breath or desaturation or decreased endurance, that means you're doing less. And when you're doing less, you're going to do less, right? Like it's that simple. Meaning, if endurance is my stopping point and I'm walking a less distance, I am no longer doing the stairs, I am now sitting, I'm increasing my sedentary behavior, you can guarantee that we're going to have a strength impairment as well. And if we're doing less, if we're sitting more, and we are now only walking from room to room to room, you can guarantee that you're going to have a dynamic balance or just balance impairment as well. So again, as much as I am niched down in Cardiopulm, I will always look at the whole person. I will stand by the trifecta to the end of time. Every patient can benefit from breathing exercises, endurance training, strengthening. And now, as I've branched out more in the world of COVID and long COVID treatment, I would throw lymph drainage on that and have that as a perfect 4 for everybody, baseline, including myself, right? If you do less, you will do less, period. But from a PT perspective, I really want to encourage you to elevate the people around you, to articulate the things that you're doing with your patients, interdisciplinary, and in your documentation, and the people in different settings. We have to continue to elevate each other, not tear each other down. And I will continue to state that because I hear it so frequently. I see it in different settings, and it just hits me the wrong way. So there's a ton more we can talk about with documentation. I don't want to go too much longer, but essentially, if you are assessing something, if you're performing an exam technique and there is a negative finding, or a positive finding, there should be some intervention that's reflecting that. And if you have an intervention that is reflecting that, then there should be a goal reflecting that. Everything should match up, okay? Make sure that when you are articulating your message, when you are providing interventions, that you're thinking about the end goal for the patient's goal too, right? Like that should be top of the list, and you're able to add that in at the end. But I know documentation can be a sticking point. I know it's a pain in the ass sometimes. It is laborious, but it helps to show our worth, our skill, our knowledge, and the effect that we have on our patients. So at the end of the day, we have to keep doing it. And if you're going to do something, you might as well do it well. So hopefully I was able to add some verbiage to your note writing, maybe give you a little clarity on what is expected in certain sections. I know I didn't hit all of them. And if you are in the mobile PT world, outpatient world, starting your own business, look into Jane. They're a great company. They're easy to use. They're totally user-friendly, super customizable. And it's just been an easy transition into this EMR. And it allows me to document the way I like to document. All right, I hope this was helpful for you. I hope I added something new to your everyday routine. If I did, let me know. shoot me a DM on Instagram, on Threads, on Twitter, on email, or text at 913-308-4494. I hope you all have a wonderful day. And whatever you have to do, get after it.